If you have been in the MEDS Ed universe at CareOregon over the last couple years, odds are really good that you've had some familiarity with our next presenter because he has been a tremendous collaborator for us in our ongoing quest to make a difference in the world of diabetes. Dr. Leonard Bertheau is a diabetologist. He cares for and manages the treatment of diabetic patients as serving as the medical director at Adventist Medical Center's Diabetes Center. He is going to give you all kinds of good information in the second half of our segment here. Please give a warm welcome to Dr. Leonard Bertheau.
Thank you. Cool. Thanks. All right. So to begin with, this is kind of the biggest point of this presentation. Dr. Ahmann and I worked with CareOregon to kind of streamline the new ADA recommendations on how to manage our diabetics. And then CareOregon said, well, let's use some of these guiding principles and let's choose a couple treatment modalities to really streamline this process. And so this, if you haven't noticed, is in your handout. This is a big reference for you to utilize when you're managing the diabetics for CareOregon. So I encourage you to get to know that pathway and to get used to that, at least with your CareOregon patients. It makes a big difference in treating the CareOregon patients. So just to quickly summarize, again, obviously start with metformin. Sulfonylurea is a good second agent. And then when you move on to that as your third agent, start thinking either basal insulin or the GLP-1 agonist. In particular, Victoza is the one that CareOregon is encouraging us to use. That's the once daily, if you remember. And in particular for the patients that, I guess I have a pointer here. The patients that have a BMI greater than 30. I really do believe that you're going to have the best bang for your buck in this population because weight loss is so paramount with this disease. The insulin are just kind of compounding to their issues as far as weight gain, and you start to add more and more insulin, and then you don't have the benefits that you want. So GLP-1 agonists are great for these patients. And then when that doesn't work, then you can start falling into basal insulin with the GLP-1 agonist, or if you've already been with the basal insulin, you can think about adding the GLP-1 agonist at this point, or of course you can always do mealtime insulin. So this is a great protocol to follow. Okay, so when should we start thinking about starting insulin? So if the A1C stays above 9%, not controlled by orals, and you've been trying with the orals for 3 to 6 months, you should probably be thinking about insulins. I personally, this is my favorite scenario. I love taking care of newly diagnosed diabetics when their A1C is greater than 10. I feel that insulin is recommended at this point because of what Andy alluded to earlier, not alluded to, but shown with studies that it does preserve beta cell function. When you get these agents involved early, I feel you take care of something called glucose toxicity. That brings the blood sugars down, allows the beta cells to heal themselves, and after about 6 to 8 weeks, I get to take the patients off of the insulin, and then I see them have tremendous results with orals after that. So I have a big bang for my buck with the insulin right from the get-go. And I start them with not just basal insulin, I start them with basal bolus insulin therapy right from the get-go. It's a fun visit. They're brand new to diabetes, and they're thinking, wait, what? You want to put me on insulin and not just once a day, but multiple shots? But then I walk them through the process, and usually I have pretty good success rate with getting them through that and seeing them on the other side with the benefits. I have patients that I've been seeing for 9 years now that have A1Cs down in the 6s, and they're on just metformin after taking care of them at the beginning like this. So the most fun thing I get to do. All right, I guess watching my son play tennis is right up there, but I still enjoy that. All right, so choosing insulin. So basal insulin, what dose, what time of day, when to start. I think we got that from our last presentation, but what did you guys learn? What dose should you start with? And you can cheat. You can look at that. 0.15 units per kilogram. What time of day is best to start with? Yeah, at bedtime, is that what you had? Let the patient decide when it's most convenient for them to remember. Yeah, I would agree with that. You know, I still personally like to have it at bedtime when possible, but I do have those patients that fall asleep right after dinner. So I tell them, why don't you take it before dinner? You remember to take some medicines before dinner, and you remember to eat. Take it before dinner. At least I'm getting it in the evening, and I'm getting it in every day. And then when to test when you're monitoring the effectiveness of your basal insulin? Morning sugars. I don't know why, but diabetics, for one reason or another, they're giving it at bedtime. They think it all depends on their bedtime sugar. And I spend a lot of my time educating them, no, it's your morning sugar. Well, yeah, but my bedtime sugar's high. It's your morning sugar. And they'll use sliding scale basal insulin, and I'm like, where did you come up with that? No, let's just stick to this one dose, and this is what we're following, your morning sugars. And still they come back and they say, well, I didn't want to give that much because my bedtime sugar was this. No. And then bolus insulin, when to add and when to test. So obviously, when should we be taking our bolus insulin, the fast-acting insulin? Before meals. Again, you'll hear from patients, well, I was told that if I take it right after meals, it's just as good. I don't hear any feedback from that. It really makes a big difference to get that bolus in right before you eat. The other drawback I hear is, well, how am I supposed to know how much I eat until after I eat? You have to do a little bit of meal planning, and I want you to take your insulin before you eat. It really makes a big difference. When you take it before you eat, it prevents that postprandial surge, and it's a lot easier to bring it right back down after the meal. Whereas when you take it after you eat, there's a huge postprandial surge, and it becomes more difficult to bring it down after the meal, and also it can be more dangerous too to bring it down after the meal. So it's safer, more effective. I say this to my patients a lot on a constant basis. And then when should you test to know how that bolus insulin is working or mealtime insulin is working? Ooh, I stumped you on this one. So you could check. I tell patients to wait at least 2 hours after a meal if you want to check after that meal. But I also try to make it as easy on them as I can. And so I'll use, if I give them a bolus at breakfast, I'll use the lunchtime blood sugar to determine how breakfast went, provided they're not snacking between breakfast and lunch. And I'll use the dinner time sugar to determine how the lunch bolus went. And then I'll use the bedtime sugar to determine how the dinner time bolus went. Basal bolus ratio, when you start adding bolus insulin in, our general rule of thumb is it's about 50-50. You'll see in real life that a lot of times the basal insulin is at a higher dose, and we start using less than 50% of the bolus insulin. But with this new 670G pump and sensor, we're actually seeing that when it's done really correctly with artificial intelligence, that the basal insulin actually starts coming down, and we start using more than 50% bolus. Have you been involved in some of those studies?
Yeah, I mean, there's actually a fair amount of data now that you look back that suggests that we had it wrong. But I think still this is where you start, but I guess where you end up tends to be more bolus.
Mm-hmm. Yep. And what are the barriers that we're going to face with our patients on a daily basis to use insulin, and what are some of the thoughts on ways to overcome such barriers? This is probably a really big point in this presentation for what you guys do on a daily basis. So barriers to the potential benefit of insulin therapy. Sometimes it's the providers. Sometimes the providers delay in the progression of therapy to reach target. We keep asking them, okay, well, we want you to work on lifestyle to get this down. And so we delay the institution of insulin. It's kind of a big deal to go to that step. And so we keep trying to say, well, if you would just do this, we could avoid insulin. And it tends to be worse with insulin than it is with other agents. It's easy to tell them to take a pill, but to tell them to start taking shots is a much bigger step to ask them to take. Then there's also behavioral barriers. Patients have their fear of injections. They have fear of hypoglycemia, insulin causing complications. And then from the provider side, we know that there's also hypoglycemia that comes with that, as well as weight gain. And then objective limitations once initiated. Once you get a patient on insulin, are they really going to take it like we've prescribed? Again, hypoglycemia and weight gain, those two keep coming up. So what are ways to overcome this? First of all, I would encourage you and providers to avoid using insulin as a threat. Please don't say, I need you to go out and exercise 30 minutes a day or else I'm going to put you on insulin. It should never be a threat. In fact, I'll tell patients right from day one, if their A1C isn't too high, right from day one, I'll tell them, you know, their big fear is, please don't put me on insulin. And if I sense that, I'll say, you know, if we ever do need to put you on insulin, don't worry about that. I know how to do that safely. I can get you on this safely. That's nothing to fear. But for right now, we have these other treatment modalities that we can try. And then once we're there at the insulin, it's nice being the specialist because usually when they see me, they know it's coming. I just have to say, and they're like, oh, I knew he was going to say that. Once we get there, I alleviate their fears. Use insulin regimens that offer maximum flexibility. So me personally, I have a lot of knowledge with all the tools, and so I just kind of present the tools to the patient, and I ask the patient, which one do you think is going to fit best for your lifestyle? And I engage them in the decision-making process, and I allow them to come up with what's going to fit best for their lifestyle. You can give them just a limited trial of insulin. So here's a big thought. If you really have a patient that just does not want to start shots, and you're thinking, well, I know they need multiple shots, a good place to start for that patient is actually just give them one dose of basal insulin, just so that they get used to the idea and the concept and the ability of giving themselves a shot. Because honestly, once they do it once, they're going to be like, oh, well, this is no big deal. And in fact, has anybody here had a shot, not of insulin, but saline, or a shot of insulin? Okay, good. I'm glad that there's some people in the room. I was looking at myself in the mirror one day, and I do this for a living, and I tell patients, it doesn't hurt. And I looked at myself, and I'm like, how do I know? So I went ahead and loaded up a saline syringe, and I lifted up my shirt, and it took me a good 20 minutes to build the courage to stab myself with a sharp object. And once I did, I was like, oh, you gotta be kidding me. That's it? And it honestly doesn't hurt. Tell the patients, oh, I guess I did this already, didn't I? Tell the patients that it's less painful than poking their finger. We have a lot of nerve endings on our finger, and so when we poke there, we're going to feel that. So here again, when we get new technologies, I try to use the technology. I'm not diabetic, by the way. I try to use the technology so that I get used to it, and I use that as an opportunity for 3 days to walk in my patient's shoes, and I'll poke my fingers for 3 days just like I'm asking my patients to do, and I hate it. It really hurts to poke your finger. And patients know that because they do it on a regular basis, and we're asking them to do it, and they do that for us. And when you tell them that this doesn't hurt like when you're poking your finger, then that alleviates a lot of their concerns. And 99 times out of 100, when they come back to me, they're like, yeah, you know what? That was no big deal. Once I took the first shot, it didn't hurt at all. And oftentimes, we can actually give them a shot in the office, and they get to experience right then and there, oh, this isn't bad at all. Teach the patient to recognize and treat hypoglycemia. So hypoglycemia is a real concern when you're using insulin. So educate them, let them know what it feels like, what they need to be on the lookout for, and how to treat it when they get it. Use basal insulin analog with the lowest hypoglycemia risk, and then dose the basal insulin at the time that's most convenient for the patient. And then meet with a diabetes educator. So here, if you have this ability, this is where a diabetes educator can really help them feel comfortable with taking shots. Okay, so here's an example. Mr. S just started Lantus, 10 units at bedtime. And when you ask him how his doctor told him to titrate his insulin, he responds, I don't remember. Have you heard that before? So when should he test his blood sugars? Morning time. What are his blood sugar goals and his A1C goals? Less than 120. A1C goal? Less than 7. Less than 7.5 is not unreasonable for a lot of our patients. And then what's a reasonable titration plan? Andy kind of alluded to this.
2 units every 3 days.
Ooh, I love that one. That happens to be mine. 2 units every 3 days is a very reasonable plan, I feel. And I guess it depends on the patient. If I have somebody who's a little less insulin resistant, I'll do 1 unit every 3 days. Sometimes I even do 1 unit weekly. But 2 units every 3 days tends to be my go-to. 1 month later, at a follow-up, he mentions that he had 2 low blood sugars this time, and so he treated it. And he treated it with 2 cans of regular soda, 3 slices of leftover pizza. Oftentimes, diabetics will use this as an excuse to finally get to enjoy the things that they've been refraining from. So I've heard in the past, oh, I had a low blood sugar, so I ate a cake. Not the best way to treat a low blood sugar. So what questions do you ask, Mr. S? There you go. How low was it? And then what key points on management of hypoglycemia do you review? I think the next slide goes into that. So hypoglycemia is, again, as a real big deal for me. For most patients, I don't want them under 70. The caveat to that are my gestational diabetics. In that one scenario, and it feels weird for me when I see them, we're allowed to have their fasting somewhere between 60 to 95. It's that important to keep their fasting blood sugars low during that time. Why worry? Because it can lead to loss of brain cells, coma, death. I tell my patients, and I do this a lot, I tell them, you know, the high blood sugars are going to do damage over years. 1 low blood sugar could be catastrophic. And so the low blood sugars are nothing to mess around with. I also give them an analogy, and this is why the plane's on here, of flying an airplane. Think about flying an airplane. If you're flying too close to the ground, you want to get up off of the danger as quickly as possible. And so I'll tell them, back off on the insulin quickly, decrease it quickly. But if you're flying too high, you've got some time. You can gradually try and come down to that sweet spot that you're trying to aim for. So the analogy of an airplane works pretty well. All right, so here are the symptoms to educate your patients to watch for. Headache, confusion, personality changes, blurry vision, hunger, nausea, upset stomach, sweating, anxiety, dizziness, and then fast heart rate. Shaking tends to be the one that is the most common for all my patients. I'll ask them, did you get a low blood sugar? Yes, I got a low blood sugar. What are the symptoms you felt when you had a low blood sugar? And they'll usually say one of these other ones and shaking. It tends to be just kind of the common pattern. Everybody experiences it a little differently, but shaking tends to be one that they all kind of share. Yeah, I was really hungry and I started getting shakes. Or another one would say, I got kind of confused, I couldn't think clearly, and I started shaking. So I'll hear that a lot. Keep in mind that a lot of these symptoms will overlap with a high blood sugar. And so whoever answered how low was their blood sugar keyed in on the fact that they really need to be checking. If you feel those symptoms, check the sugar and confirm that it really is low. I had a patient once who thought he was low. He treated the low blood sugar and then felt 10 times worse right afterwards. So then he decided, well, maybe I should check my sugar. And he was well over 500. He ended up in diabetic ketoacidosis because he didn't check his sugar the first time around. Had he checked, he would have said, oh, I'm not low. I'm actually high here. I need to be aggressive with bringing my sugar down. Not what he did was overly indulged again. Yeah. The cake, yeah, stay away from the cake. So how do you treat a low blood sugar? So we have something called the rule of 15. In the patients who are awake and able to take oral intake, we ask them to use 15 grams of simple carbohydrates. So some examples of 15 grams of simple carbohydrates is 4 ounces of orange juice, 4 glucose tabs, 5 lifesavers, a half a can of regular soda. I'll tell patients, go ahead and have a can of Coke in the back of your fridge and just leave it there. And if you ever need it, drink half a can. And then nothing with fat or protein, as this will slow absorption of glucose. In my pathology class in medical school, one of the answer choices to treating a low blood sugar was a candy bar. And even at that time in my training, I knew, well, there's fat and protein in there. It's going to delay the absorption. I would never tell my diabetic to take a candy bar. I got the question wrong. I was so mad. I confronted him after class, and he's like, "Hey, all your colleagues said candy bar. Sorry, you got it wrong." I'm like, "It's not right." He didn't have any other good answers either, so I should have went with the candy bar. But for our patients, don't use candy bars. The glucose tabs. Has anybody ever tasted those? Yeah. If you've tasted it, they don't taste great. There's a reason, I believe, for that. Do you know why that is? Because it'll be there for you when you need it. I had a patient who hid, again, going back to the candy bars, he hid candy bars all over his car so that in case he had a low, he would have a candy bar. Well, guess what? He actually did have a low, and there were no candy bars to be found. He found them all. But those glucose tabs, they'll be there for you when you need them. Because when you don't have a low, they don't taste great. But when you have a low, you don't care. You just treat the low. And then if patient is not awake, this is when a loved one or a family member should be giving glucagon. So don't forget about when you're giving insulin prescriptions to give them glucagon or make sure they have glucagon on hand. And more importantly, make sure that the person who would be delivering the glucagon knows how to use it. I always tell the patient, I said, whoever would be giving this to you, make them go to the pharmacy with you and have the pharmacist teach that person how to use the glucagon kit. Another episode, I had a patient who had a catastrophic low blood sugar. He went out on the floor, and his partner knew that he had glucagon, knew what the glucagon was used for, and decided at that moment to take out the instructions and learn how to take the glucagon, or how to give the glucagon. And he was shaking, and he was trying so hard to understand how to do it. He ended up doing just fine, but that's not the best time to learn. Make sure you know ahead of time.
So for those patients who have uncontrolled diabetes for so many years, and the goal of blood sugars don't even come across blood sugars, and they feel the shakiness, they feel the high blood sugars.
Great question. Actually, it's coming up, so I'll address that. So going back to the rule of 15s, so 15 grams of carbs, and then recheck in 15 minutes, and make sure that it's gotten up over 70. And then once it's up over, if it hasn't gotten up over 70, you repeat that. Give another 15 grams of carbs, and then repeat in 15 minutes. Once it has gotten up over 70, then you can start to feed them with things that are more stabilizing to their blood sugars. Things with protein like peanut butter, or you can feed them a meal if their blood sugars are back to normal. All right, so this is, oh yes, I have a question in the back.
I got a question. Does CareOregon pay for glucose tablets?
Ooh, good question. That's a great question.
Yes, we do.
Excellent. I didn't know that.
That's actually really good because a lot of insurances don't.
Yeah.
And many patients don't want to get them because they
Costs
feel
money.
shaky in their pocket.
That's good to know. All right, so now this is going back to your question. So a normal blood sugar can cause symptoms to some patients. If they're used to walking around with 300s, a 130 doesn't feel good to them. And also, a 130 could actually be a point that you catch it, but it's actually dropping from there. And so I educate my patients in both of those aspects. Well, some of this is we have to get you used to feeling normal again. But at the same time, you don't want to ignore these symptoms because it could be a sign that you're falling quickly. And so what I'll tell them is keep a close eye on your sugars. Don't be afraid to recheck. And then if the symptoms, if your sugars continue to drop and the symptoms are quite severe, please treat. But at the same token, I don't want you getting used to 200 is your normal. 200 is not your normal. Your normal should be in the 100s. We'll get you there eventually.
I actually had a patient who had been living at 200 and then through diet brought her sugars to normal. But was suffering from chronic condition. Very severe chronic condition. Is that going to pass with?
Yeah, I'll see that with, not so much with diet control, but with my patients my new onsets that I get them down to goal right away. they do get headaches with that shift in blood sugar. And I tried to underguess on their insulin needs so that I make it a more gradual transition, but every once in a while I do a perfect guess and it puts them right to normal, and I'm like, ooh, whoops. And they can get headaches. Usually I tell them that passes, give it a week or two, and oftentimes it does. And if it doesn't, then you've got more work to do on that. Yeah, I think I mentioned this. Pay attention that rapid drops can cause symptoms. There we go. Okay, so at Mr. S's next follow-up, he brings in his meter this time. Yay! His sugars are at goal first thing in the morning, but are in the 200 to 300s at lunch and dinner time. So what should we be thinking now? I hear lots of little small guesses. Go ahead and speak up.
Oh, I said that you should quit having donuts with this breakfast.
Oh, there you go. Quit having donuts with breakfast. So it's the carb load at breakfast that's causing him the problems. That's right. And we can't fix that with basal insulin. So what would you recommend? And when should he test? I guess he's testing at the right times. Before lunch, dinner, and at bedtime would give us an indication of how dinner is doing. And I think I heard the right answer. Say it again.
Take a bolus of insulin prior to.
There you go. Take a bolus insulin before these meals. We have clear evidence that he needs a bolus insulin before breakfast and before lunch, right? So these are the blood sugars. At last visit, he was started. So we took that information and we started bolus insulin. So he was started on Novolog, 4 units with breakfast, 6 units with lunch, and 6 units with dinner. And now he brings in this blood log. And so this is very full of information here. So I encourage you to look at these blood sugar logs. This tells a lot of the story of where patients need help most. So in the morning time, his blood sugars are pretty spot on, right? So we know one thing. We know that his basal insulin is at the right dose. Please don't change the basal insulin. Although, like Andy alluded to, the basal insulin is bringing him down from a high blood sugar down to a low blood sugar. So once we start getting him to normal blood sugars at bedtime, we actually may need to back off on the basal insulin. Keep that in mind as well. I think we have another clear evidence here as well. We gave 4 units at breakfast, but how is that doing by lunchtime? Yeah, we need more insulin at breakfast. Again, I just want to reiterate, make sure that there's not a snack going in between breakfast and lunch. If there is, then you might start asking them to take a bolus with their snack as well. And then what about lunch? Are we giving him enough insulin at lunch based on those dinner sugars? Yeah, it's hard to tell, and this is real life. This is what patients will give you, so you kind of have to piece the puzzle as best you can. This one, it's clear that he didn't get enough insulin, but I'm also wondering, did he even take insulin at lunch? It looks like he didn't check his sugar, and he might not have taken his insulin. In fact, I'll ask patients, if you don't get a chance to check your sugar, are you still taking your insulin? A lot of times they say no. I still encourage them, even if you're not checking your sugars, please take that insulin before you eat. You still need to cover the food that you're going to eat. And then this one, I do have a blood sugar, and then by dinner it was fine. Here, he probably skipped lunch. So I don't know that we have clear evidence that he needs more insulin at lunch yet. We certainly have evidence that he needs more insulin at dinner, because his bedtime sugars are consistently high. Go ahead.
Would you ask them to do a log on what they're eating?
Sometimes I do, yes, because I'll see that they're taking their insulin just like I ask them, and I see a ton of variation in their sugars. So that's when, well, write down what you eat can be very beneficial, and you can start to see some patterns. Well, here, when you're eating a lot of carbs, your sugars are sky high, but here, when you just eat a salad, your blood sugars do well. And so you can kind of help dive into the diet aspect of the impact on their sugars. So for this one, oh, I guess we didn't say, but we would increase the pre-breakfast insulin to maybe 6 units and increase the pre-dinner insulin to maybe 8 units. And I'll tell patients, keep going up until you start seeing, like for example, for this guy, I think we're in the ballpark with just increasing the breakfast, but here we got a lot of work to do. So I might tell him, go up to 8, but I want you to continue to increase that by 2 units every 3 days. And bedtime sugars are more consistently under. And I use a bedtime target of 180. I want them to go to bed a little on the safer side so that they don't have the overnight lows. So the follow-up phone call. You collect recent blood work sugar values, and over the past week, his sugars have been high first thing in the morning and low at dinner time. And he tells you he loves watching the Olympics. At the time we did this the first time, the Olympics were going on. But all of his favorite events happen to be in the middle of the night. And so what are some follow-up questions that you can ask Mr. S? What are you eating while you're watching the Olympics? What dosage change would you recommend for the snacking at night? I think I heard bolus. What was the other one? Same? Bolus with snacking. And then what additional education could you provide on his snacking options? Low carbs. Mm-hmm. Very good. All right, so does anybody know about the dawn phenomenon? So you get a hormone surge, all of us get a hormone surge between 2 and 8 in the morning when we're about ready to wake up for our day. This causes cortisol, glucagon, and epinephrine to release in our body. We get hepatic gluconeogenesis, and most of us who have a functioning pancreas, along with that, we get endogenous insulin release. But for your diabetics, oftentimes they don't have a functioning pancreas, and so they won't get that endogenous insulin release. So this is why they can wake up with higher blood sugars. So how can we treat or prevent that? You can find a nighttime snack that actually turns off the liver overnight and prevents so much gluconeogenesis throughout the night. I like to use a handful of walnuts. A handful of walnuts has some fat and protein in there, and it distributes the carbs all night long to help turn off the liver overnight. And I'll see patients by just having a handful of almonds or walnuts that they wake up with better blood sugars. And then also medications could be wearing off. If they're taking their basal insulin first thing in the morning, that is a potential that it's wearing off by the next morning when you need it the most. So this is why I tend to put it in at night. And then also rule out the Somogyi effect. Anybody have an idea what the Somogyi effect is? So it's when you're on too much basal insulin, I think that's the next slide, and you actually get a low blood sugar in the middle of the night, and then your body releases all these counter-regulatory hormones, and it brings the blood sugar back up. And so by morning, you actually can see a high blood sugar.
The people who work evening or night came to the treatment of their diabetes.
Yeah, so those are difficult. My best option for those is to stick with a regular schedule. So on their days off, whatever their morning is, just keep it consistent. And then you do have to say, okay, take your basal insulin when you go to sleep for your day. And then take your first bolus insulin when you wake up for your first meal of the day, whether that's dinner or lunch or whatever. And so I'll start using terms like first meal, second meal, third meal. What they do though is they want to join the rest of the world on their days off, and it gets all flip-flopped and it becomes very difficult.
So this hormone surge happens in sleep no matter when that sleep is?
Correct. Mm-hmm. And then if you suspect the Somogyi effect, what you can do is decrease the basal insulin, and the blood sugars will actually get better in the morning. And so if that happens, then you know that they were probably having overnight lows. Be thinking about this if they're on really high doses of Lantus, and as you increase, they start waking up with higher sugars. That's a telltale sign. And then you can also refer to somebody who does continuous glucose sensors. And we can catch this overnight, and we see this in the middle of the night. They'll drop low, and they'll bounce up high the next morning. Okay, so here's the slide where I get to talk about 70-30 or split mixed insulin. It's got both fast-acting and long-acting all in one shot. So what are the benefits to that? It has basal and bolus or prandial coverage all in one injection. Well, 2 injections, a shot before dinner and a shot before breakfast. It's less injection, it's only 2 shots. It's less confusing. You just tell them this is your dose in the morning, this is your dose at night. Simple. And then 1 insulin a vial may be realistic for some of these CareOregon patients that have a difficult time keeping their insulin on hand. And so if you just have to deal with 1 insulin instead of multiple regimens, it might be a good option. The drawbacks is you're stuck with 70-30. 50-50 is, again, ballpark where it should be with the other basal bolus insulin regimen. But this is 70-30. It's less flexible, so there's not a lot of variability with their dosing and with what they're eating. And it requires the patient to eat consistently with their time and their carbs. So where this works best are the patients that are creatures of habit. They tend to eat the same things at breakfast, lunch, and dinner, day in and day out. For those patients, I feel it really is easy to just add this into their life. There's not a lot of patients that are like that. For some patients, again, I meet them where they're at. I say, here are your two options. They like the shot just twice daily. And then I tell them, well, this is what I need from you then. You need to be consistent with breakfast, lunch, and dinner. And if they can commit to that and see that through, then it works pretty well. In reality, though, that can be very difficult to do.
One misunderstanding about 70-30 that I find I'm correcting with our residents a lot is that they actually think that the shot provides like a rapid acting control and long acting, and it's really just that intermediate. I feel like that's important to call out.
Yeah, no, that's a
There's
great...
this like misunderstanding that somehow they've been mixed, and so they can still affect like a quick control for postprandial and a long acting, and it's really more just that the peak is
Correct.
further out.
So the way I draw it out for my patients, and I kind of wish I had this here, I think you've got it in one of your handouts, is you take it before breakfast, and it gives you fast-acting insulin for breakfast, but then it also gives you that intermediate-acting insulin for lunch. And so with one shot, you've taken care of breakfast and lunch. And then you take another shot before dinner, and it takes care of that fast-acting insulin for dinner, and then the intermediate-acting insulin for overnight, just like your NPH that you would take at bedtime. And so with two shots, you're taking care of breakfast, lunch, and dinner, and overnight. But you're right, you have to take a shot before breakfast and a shot before dinner every day to get that. All right, so let's go through a case presentation, Mr. T. Mr. T said he was too busy to remember to take his insulin. He works in a warehouse loading trucks locally made bike bags. His job requires to take lunch and breaks at regular intervals, so we can depend on a regular lunchtime, and his coworkers' breaks. And coordinate with his coworkers' breaks. So Mr. T's doctor started him on this 70-30, started 20 units, 30 minutes prior to breakfast and dinner. So we're just starting 20 and 20. It's important to note that if this is Novolin 70-30 or Humulin 70-30, you should give it 30 minutes before the meal. If it's Novolog 70-30 or Humalog 75-25, you should take it right before the meal. Or within 15 minutes before the meal. So why is it important for him to take 30 minutes before breakfast and dinner? I think I just said that. And then how can you double check that the dose seems reasonable? Yeah, check the morning sugars and then the pre-dinner sugars. Those are the two sugars I need. So you call him for a follow-up last week, and he had 2 low blood sugars in the afternoon. I tell patients all the time, I say, if we're going to do this 70-30, you cannot skip lunch. Don't skip lunch. And oh, by the way, did I mention don't skip lunch? And they're like, okay, I got it. I won't skip lunch. And then I see them in follow-up, and they said, I had low blood sugars. And I said, what happened? I skipped lunch. So it's a really big deal. They have to commit to eating lunch every day. And so you call. He said he had 2 low blood sugars in the afternoon. He said his job has been very stressful, and one of his coworkers has been calling in sick, so he hasn't had the ability to take his lunch breaks. He even skipped lunch twice to cover the shift. So could this be causing the lows? Duh, right? And then what education would you provide Mr. T? Do lunch. And in reality, if it's not going to happen, then this isn't the right insulin for you. Then you should take a long-acting insulin with fast-acting insulin before breakfast, and then on the days you skip lunch, you would skip your fast-acting insulin. I also want to make out a big point. I thought it was going to be in this presentation. Patients have a really hard time with this. So he starts 20 and 20. Let's just say his morning sugars are perfect, and his dinner time sugars are high. Which dose would you increase? Morning, oh, you guys all get gold stars. It's the morning insulin that covers breakfast and lunch, and so if dinner time sugars are high, he needs more insulin at breakfast. That's really hard for patients to wrap their head around.
One thing I would be concerned about too is if his lunch, because some of my patients, their lunch in the Hispanic community is the biggest meal of the day. And so I would probably recommend you want to have them test before lunch and before dinner to see that pattern.
Yes.
You know what I mean?
Yeah, that's a great point.
Because I'd be worried about increasing that breakfast dose.
And then they start dropping low after breakfast. Did everybody hear that? So what she was saying is in the Hispanic population, they have a huge lunch. And so you're thinking they need more insulin with the 70-30 at breakfast so that their dinner time sugars come down. But a good thing to think about is check a blood sugar before lunch to see, are you giving them too much of the 70-30 for their breakfast? And maybe they're not eating the breakfast that would accommodate 70-30. So for them, this regimen might not work. Or you can ask them, eat a lighter lunch and maybe put some of that at breakfast, whichever would be easier for them. All right. So when should we refer to the specialist? So a new onset diabetic, again, for me, this is my favorite patient. Certainly if their A1C is above 12%, I feel like they should be hit hard at the beginning so that we can get their A1C down. Otherwise, if you're throwing pills at them, it's going to take a long time for them to come down. I do believe at least north of 10%, you have a chance of bringing their A1Cs down and conserving beta cells with the GLP-1 as well at the front. The higher you go, the less likely that's going to be as effective, but it still can be if they're really committed to a change in their lifestyle. So you could start them on a GLP-1 at the beginning as well, but insulin always works for these patients. Uncontrolled diabetics, if they're already on basal insulin therapy and they're still not controlled, and I see this a lot, maybe get an expert involved so that they can find the finer nuances to make sure that their regimen is right for them and start bringing down their A1Cs. Gestational diabetics, I feel that if a gestational is diet controlled, that can be managed most appropriately by their OBGYN or their primary care doctor if you're managing their gestation. However, once they start requiring treatment and they're not at goal, they can be managed with a specialist. Type 1 diabetics, does anybody here feel comfortable managing type 1s on their own? Oh, excellent. So that's another area where we can be very helpful. And then insulin pumps. I think you're going to start seeing that insulin pumps are going to get used more and more. Insurances are starting to pay for them more. Sensors are getting paid for a lot. And we have the capability and the know-how on how to use all of that technology. I was working out the other day and I saw multiple diabetics in the workout room that were using Dexcom sensors. I was so impressed. I was like, wow, that's so cool. And they weren't all my patients. All right, so things to think about outside of the box here. There's more than just true type 1s and type 2s. There's other diagnostic considerations. Has anybody heard of LADA, latent autoimmune diabetes of adulthood, or type 1.5? So a couple people have heard. Really, all this is type 1 that gets diagnosed later in life. And it has a different presentation. When you're a young child, your immune system is very robust, and so it attacks and destroys your pancreas pretty quickly. You can get a honeymoon phase, but the honeymoon phase is usually pretty small. When you get this later in life, it can present very differently. So for some patients, their beta cells are killed off, but not a lot. And so you can manage some of them as type 2. And then as the years go by, sometimes that changes. So the picture can change on you as you're managing. And some of them get really frustrated. They're like, Doc, I don't know what's going on. I'm exercising, I'm dieting, I'm doing everything right. And it looks like I just have to have more medicines. And I tell them, well, this isn't that kind of diabetes. I'm glad you're dieting and exercising. That's still good for you no matter what. But because you have to have more insulin, that has nothing to do with the fact that you're not doing what you're supposed to do. So sometimes it helps them to understand that their efforts aren't in vain. It's because of the disease process. Has anybody heard of double diabetes? It's a term that I was exposed to These are type 1s. These are true type 1s that also have insulin resistance. So these are our larger type 1s. These are our type 1s that I have one in particular that has a family history of type 2. Had she not developed type 1, she would have probably developed type 2 later in life, or maybe even earlier in life. But she's a type 1, and she has insulin resistance. So she's a particularly difficult patient to manage. There's other issues with her as well. Yes. Mm-hmm. Yes. And I use that with this patient, type 1 with metformin. And then there's other forms of secondary causes. So diabetes from anything that can injure the pancreas, pancreatic cancer, alcohol, surgery, yeah. Okay, so here's a couple real life cases that when I first got to the Portland area, I saw, and it was so much fun. So I want to share with you. So a 44-year-old male with a random serum glucose of 271. Now this is a serum by venous draw, and it was random, it wasn't fasting. And he's also been having symptoms of frequent infections, polyuria, polydipsia, and weight loss. So is this diagnostic for diabetes? It is. A one-time random with symptoms, serum glucose is diagnostic. That's the one time you get to make the call after just one. There's also a stipulation in the American Diabetes Association that says in unequivocal hyperglycemia. Well, what does unequivocal mean? If he had a blood sugar of 500 without symptoms, I think that's unequivocal. But where's the cutoff? Yeah, there really is no cutoff. So I have enough to make a diagnosis, but what type is he? So here's more about him. He had weight loss right before. He's 5'9", 197, so his BMI is 29. Not perfect, but not terrible either. His maternal grandmother was a type 2 late in life, and she was very obese. There's no signs of insulin resistance on him. He didn't have what's called acanthosis nigricans, or the darkening of the skin in the neck. And his A1C was 12.5, and his blood sugars range anywhere from 170 to 508. So which way are you leaning, or which way do you think he is? Type 2. Think that's reasonable? So type 2, type 1, LADA, this latent autoimmune diabetes of adulthood, double diabetic, or other types from secondary causes. I didn't know for sure, but I was thinking he's either a LADA or a type 2. So I did antibody testing. I did anti-insulin, anti-GAD. I don't do anti-islet cells anymore. And then I also did a fasting C-peptide, which would let me know how much is his body producing, how much insulin is he producing, along with a fasting serum glucose. All of his autoantibodies were negative, so I don't know that he's a type 1. His C-peptide was low, so it doesn't rule out that he is not a type 2. Was that confusing or what? So I still really didn't know. So because he's not producing insulin, it doesn't mean he's type 1 or type 2. It means that he's either a type 1 and not producing insulin, or he's a type 2 in glucose toxicity and not producing insulin. And because he doesn't have the autoantibodies, I can't say he's a type 1. But in LADA, you can see that presentation, and they won't have autoantibodies. So I still don't know. So I asked him to check at home. His fasting sugars are 178 to 298. 2 hours after breakfast, he goes sky high, 390 to 500. And he only gave me one bedtime reading of 295. So what's the best way to treat this person? I heard a guess. Go ahead and say it out louder. Insulin. Oh, great answer. Would you start with just basal insulin? No, it's pretty clear he needs mealtime insulin, doesn't he? So I started him on basal bolus insulin therapy. I felt like, well, if he is a LADA, I've got him covered. And if he's a type 2, this is going to reverse the glucose toxicity, and after about 6 to 8 weeks, we should be able to get him off of insulin and just maintain him with oral medicines. So I've covered him both directions, and I explained this to him. He's a really smart patient, and so he understood the concept of carb ratios, and so he picked up on that, and he went running with it. He continues to this day, and I just saw him last week. He continues to this day using basal bolus insulin therapy. So I do believe he was a LADA, latent autoimmune diabetes of adulthood. His A1C last time was 6.6, and he's not getting any lows. So I don't see that very often with a true type 1, so I do believe he's got pancreatic function, but he still requires basal bolus insulin therapy. So he's still doing well. I love seeing him. All right, go ahead.
One thing I'd like to mention that case brings to mind just the very first part of it, and it actually relates to a patient we had recently that I think might have come from Virginia Garcia, was for our grade trial where you have to be on metformin. We had a Latino patient late in the process, who was interested, really wanted to be in our study, but he had an A1C of 11.5%. And our coordinator came to me and said, this guy so much wants to be in the study, but he has this really high blood sugar. We need to get him down to 8.5%. I don't see any way that he's going to get there over the run-in period that we have to meet the criteria. And I said, well, if he really wants to that badly, why don't you talk to him? Because a lot of times when people with type 2 first get diabetes and they get thirsty, they get symptomatic, they start drinking large amounts of fluid, but they don't drink water. They drink soft drinks or they drink something that has high glucose content. So they called him, and indeed, he was drinking some fruit concoction that was common in his family, and he was drinking lots of it, and he quit drinking it, and when we ran him, finished the run-in period, our only risk was that his A1C dropped all the way to 7.2% on just metformin, and he had to be above 6.8% to get in the study. So he got into the study, but it just shows you how sometimes you have to take that into account with the people who are newly diagnosed and are symptomatic, is that they're really thirsty and they're drinking the wrong thing. So
that's a great point.
Does CareOregon cover all that autoantibody tests?
Is that a care? Yeah.
Yes.
Do you guys know?
Yeah.
I guess these are. Yeah.
I was just curious. So would you also started this fellow on metformin as well?
I think I did, and I think I took him off of it pretty quickly because he didn't tolerate it very well, and it didn't seem to be helping his situation. The insulin had the best impact for him. You're taxing my memory, though. All right, so this next case, again, right around the same time that I met the 44-year-old. This is a 43-year-old male. He's, at the time that I met him, 6'2" and only weighed 114 pounds. He was down to 90 at one point. He had actually gained some of it back. For 2 to 3 years prior, he had his blood sugars checked by his partner's dad's meter, and it was over 500. At the time, he didn't even know what that meant, so he just ignored it. The reason I saw him, he was formally diagnosed with diabetes 6 months prior to meeting me. He had lost 60 pounds in over a year and a half, and he was eating a ton. He felt like he was going to die, and his A1C was 10.2%. He was referred to me by the wound clinic because he was there for a foot ulcer. He had no other symptoms. However, when I questioned him further, he did admit to having chronic diarrhea about 8 times a day, having oily stools, and he admitted to a history of heavy alcohol consumption. So, yeah, So what type of diabetic is he? Type 2, type 1, LADA, double diabetes, or secondary causes? And what's the secondary cause? Alcohol, chronic pancreatitis. That's exactly what it was. So other types secondary to chronic pancreatitis from alcoholism. An abdominal CT can confirm this diagnosis and can also rule out pancreatic cancer. One thing with weight loss is it could be cancer, so it's a good study to rule that out. He wasn't checking his sugars prior to meals, prior to his initial, he wasn't checking his sugars at all prior to his initial visit. So what would you treat this person with? Yes, that's a great answer. Stop drinking. Basal bolus insulin, the one thing about insulin is it works in every case. So I started him on basal bolus insulin therapy. I also gave him pancreatic enzymes to take before each meal. And on an update follow-up visit with him, he had no more diarrhea. His weight was up to 136 pounds. His A1C was 6.8. He was starting to have some low blood sugars, and so I had to adjust his insulin regimen. And he did cut way back on alcohol. At that time, he was continuing to drink. I did get him to a period where he actually stopped drinking, but in recent follow-up, he started drinking again, and he's drinking more than he used to. And so I still don't have a good prognosis on him, but his blood sugars continue to be fantastic. So some take-home points. Evaluating blood glucose readings can be very helpful in identifying potential issues with diet and or medications. Educating patients on the timing of their insulin dosing is key. And then insulin regimens should be individualized to the patient's schedule, lifestyle, and social determinants. One of the reasons why at my facility we thrive is because of my medical assistants and my staff. And one thing that they do for us exclusively is every time I go into a patient room, they pre-scrub the chart. And they let me know when my diabetic is due for anything. And I can quickly look in one spot in my note at this dot phrase that they put into Epic, and I can look and see this patient is due for fasting blood work, a foot exam, and that's it. So I can take care of that while they're in the visit, and that really streamlines things for me. I can just quickly address those and then move on to the main reason they're there. Sometimes I get behind in schedule, and sometimes patients become very complex, and so I don't even get a chance to get to this part. And then we have my staff member, again, who's stellar, follow up with the patient and say, oh, did he get your fasting blood work ordered? And they said, no, we didn't address that today. And so she'll order it for me. So it's a team effort, and they're making sure that we're meeting all of our benchmarks here. And we do a pretty good job of hitting them all. So this is a great process to have. It's nice that all my patients are diabetic, so they do this for every patient. They also help with coordinating supplies. This is just offloaded off my shoulders. They work on getting the patient a meter that's covered by their insurance. They work on getting the strips and the prescriptions sent to the right place and getting them covered. They make sure the patients have lancets to go with it. They also help with my syringes, the pen needles. They teach the patients how to use these for me, so I can come up with an assessment and plan, hand the instructions over to my MA, and they go in and do the work for me. They also go through control solution, batteries, alcohol swabs. They take care of all the little things for me, and I can't overstate how important that is for the success of our center. All right.
Let's give a big hand to Dr. Bertheau.
Thanks.